The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. It's always interesting to me when we get to talk to people who are slightly outside the realm of what we do on a daily basis, but who comment on the things that we absolutely do on a daily basis. We're very fortunate this month to have Dr. Dedee Caplin with us to talk about pain issues. Dedee has been here for a while, right? You clearly joined the department when you were about 14, because you've had various roles within the department since you came, isn't that right?
That's absolutely right. I was 14 back in 2001 when I joined the department. But yeah, I have worked in the Department of Pediatrics up here at the U for a couple of decades now. Yeah.
And a renowned prodigy. You were Associate Program Director for some time. Tell me about what your focus is now, because I think it's very interesting.
Yeah, so my focus now is actually on the integration of mental health care or behavioral health care, as we think about it, with medical care. What we're finding out is that when we work collaboratively, we are actually much more effective at doing the things that kids need to be doing in order to be able to function effectively in their daily lives.
That is such a weird and completely logical thought.
I mean, it took a long time to get there.
We're still getting there, right? It's still a process. You got your PhD at Ohio University and then did your pediatric training at Louisville. Are you from Ohio originally?
I am not. I grew up in Southern Ontario, so just on the other side of Lake Erie from Ohio.
Oh, okay. Great. And now, 20 years
later.
And
now I'm a Utah. Yeah.
Wonderful. As we've been thinking about how to approach this, I realized that we maybe could have done like 10 episodes to help us understand this better before even starting any of this. But I think you've been very patient with me in trying to figure out a way to talk about this, because what we want to talk about really is that treatment of pain by itself. We're going to talk about it from a framework, I think, of medically unexplained symptoms and that sort of pain. But there are implications for pain, which is a big part of what we do in so many things. Am I misreading that?
No, you're absolutely right. I think that pain can be present and persist even when there's no clear physical cause, even when what we think was causing the pain has healed. And what we're finding out is that pain can be a problem in its own right rather than just a sign of something else.
And even when it is a sign of something else, treating the pain, we often have done that either inadequately or misguidedly.
I don't know if it's misguided, but I do think it is inadequate. When we think of pain as a symptom of something else, sometimes we think the treatment of pain is just treating the other thing. But there are lots of things we can do to make pain better and to make people more functional when they are experiencing pain and discomfort.
And I think what I meant by misguidedly is I think there is a long history of a pharmacologic approach to pain that has not been very helpful.
So the evidence is pretty clear. For chronic pain especially, there aren't really any medicines that are super helpful.
Yeah. This is not an uncommon problem among my patients, right?
So it's very common, and if you start to really look at it, it accounts for a significant portion of doctor visits, both subspecialty visits as well as just primary care practice.
And not only costly in terms of time, but costly in terms of what it costs the medical system to treat pain in this way.
So it's in the billions of dollars. It's one of the more complex things to treat. And when we look at it from a cost, the financial cost is really in persistent, inadequate care that families are dissatisfied with. And so it tends to escalate care repeatedly and over time without really good result. But if you start to add in missed school days, missed work days, people changing their entire lifestyle around pain disorders, the indirect costs are probably much higher than the direct costs.
Some fascinating statistics you shared. Over half of children and adolescents report at least one pain symptom in the prior 2 weeks. About 10% of children and adolescents have clinically significant impairment from symptoms at some point, and that up to about 50% of primary care time spent is spent on pain and medically ambiguous complaints.
I think the average clinician probably would not disagree with those numbers. All you have to do is look at your schedule morning to night and you're like, uh-oh, what's going to happen? And I don't know about you, but even in my clinic, when I think about my pain patients, I don't want them to be my 4 p.m. Friday afternoon patient. Like, I know they're going to be more complex. I know they're going to take more of my time, and they're harder.
Right. And one of the problems, and we'll talk about this more as we go along a bit, is that we respond emotionally to this problem as well. We are not very good medical machines sometimes.
I don't want to diss my, physician colleagues.
Oh, diss me.
But I do think pain in its own right, again, if we have an identifiable cause and we're like, oh, yeah, your leg hurts because you broke your leg, that's a pretty easy sell for the patient, the family, and the clinician. But I think where it becomes more problematic and where it becomes harder is when pain is actually the problem and it's not, tied to something else. That's when it really becomes much, much harder because we don't have that ready thing in our back pocket to say, oh, this is how we treat this and this is what happens.
Because clearly the most satisfying interaction is the ones where you come with a problem, I can name this problem and fix it on the spot, and everyone goes home happy. I mean, I think the classic pediatric example of that is a nursemaid's elbow. That there's this mysterious problem, the child arrives in clinic, often as I'm describing what I think is going on, I fix it, and people think I'm some sort of wizard. And that happens very little in my practice.
And is probably never going to happen with chronic pain.
Exactly. Right. Which makes this category much less potentially satisfying. Although what you're going to tell us over the next couple of weeks is that there's a much more rational approach that we can take to this, that we can actually help people.
Yes. Like, I actually don't mind treating kids in pain. And I am actually quite passionate about kids who can't go to school because I know I can get them back to functioning. And I know that I can get them to a place where they can manage themselves and their symptoms much more effectively. But I would agree. I think for the average clinician, we think about it in a way that's likely impairing our ability to treat it rather than helping our ability to treat it.
And we may actually make the problem worse in the process.
There are lots of ways we can make it worse. And I think it's funny because when I really think about like how we make it worse, that medical escalation, that continued trying to look for something that we can treat, look for something that we can do something about right away, oftentimes reinforces the entire pain process. And as a result, escalates care, escalates cost, escalates dissatisfaction because all of those results are likely to come back negative.
Yeah, it escalates anxiety, mine and the patient's. And I think this instance where we're talking about is multifactorial. And also what we're really hoping to do is provide a solution, although it's not necessarily the one that we thought we were thinking about when they walked in the door. Does that make sense?
Yeah, I think it makes sense. In the same way that we think about other complex disorders, if we could put pain into that category and think about it more broadly and more complex from the start, we might actually get farther earlier on.
Okay, explain to me what pain is. Why do we have pain?
Well, there's a number of reasons why we have pain. I think the first easy one is it's our body's warning system, right? It's our body's way of telling our brain, get out of there, something is happening. Right? Where is that harm and how do we get away from it? And I think the interesting thing about that is that alarm system can go off with a real threat or an imagined threat, which is why we say ow before we touch that stove, or why we say ow when someone's coming at us. We already know what's going to happen. And learning then becomes a process of part of the pain process in the terms of those neural connections, right? They're strengthened by experience. They're ways that we look at things and say, oh, I remember that hurts. I don't want to do that again. I think too, you mentioned fear and anxiety, both the patient and family, but also ours. Any kind of emotion can create a pain response. And part of that is those more complex parts of our brain that are involved in regulating pain or understanding and interpreting pain signals are also interpreting other sensory signals and other emotional signals. And so there can be a lot of cross wiring and a lot of cross learning that's happening at the level of our nerves that is then impacting what that pain experience looks like, which is why pain becomes more responsive to emotion, more responsive to stress. Think about anybody in pain, they tend to be more irritable. Those things just feed off of each other in a very natural way. But I think reminding yourself that it's not just damage to the body, it can be simply a nervous system response to some sensory information coming in.
So when my response is, oh, so you're saying it's all in my head, how do you respond to that?
Well, I think technically it is, right? The data does suggest that it resides in the brain, right? And your brain is in your head. So in a very technical sense, it is in your head. But I think a lot of times when kids say, I've heard it's all in my head, what they're telling you is they feel dismissed. They feel that people are not validating their pain experience. I have a lot of kids who say things like, when I tell my doctor that I'm in pain, they say, well, you shouldn't be because you're 6 weeks out from, your cast coming off. And that message of you shouldn't be, for us, I think conveys a misunderstanding of where the pain may be generated. Is it generated from the nerves? Is it generated from the internal process? Or is it generated from, the broken foot or, whatever it was that was, the surgical wound that was healing? And I think ultimately what it comes back to is we're ignoring the fact that on some level, that actually doesn't matter. And on every level, the patient's experience of pain is what matters. So if I come to you and say, I'm in pain, as the clinician, probably the best answer is actually to say, okay, tell me more about your pain. Let's try and figure this out together. And I think that a lot of times our uncertainty comes across as dismissiveness, and that dismissiveness then gets interpreted as the doctor thinks it's all in my head. And maybe sometimes we do think it's all in your head.
In some ways, it's sort of like we're authorizing people to feel pain, right? That you have no business feeling pain right now, misses the point entirely. If someone has pain.
Yeah, I don't want to be dismissed when I go to the doctor. You don't want to be dismissed when you go to the doctor. And
Right.
and I think that experiential piece of it is part of what makes pain hard to treat, because what we've just done in that teeny tiny interaction is actually increase the likelihood that the pain response then escalates, because the brain is getting reinforced in it has to be a louder signal in order for it to be heard.
So are you suggesting I'm supposed to listen empathetically?
Absolutely. Absolutely. And listening, it's funny because I often will teach residents about listening, and that listening and communicating are both really, really great interventions for pain management. If all you did was listen to your patient's full experience of pain, this is what it feels like to be me. It's painful. It's uncomfortable. It's obviously something you're going to have compassion for.
I think it was Sir William Osmer. I think I'm going to paraphrase this badly, but said, listen to your patients and they'll tell you what's wrong. The fallacy here, I think, for us is that what we're hoping then is it's something that we can put a check mark by and fix easily, as opposed to fix with a global approach.
Yes.
Okay. All right.
I agree.
So anything else we ought to know about a rationale for trying to do this better?
I think the biggest rationale for trying to do this better is to actually get patients to feel better faster. I think the sooner in the process that we introduce the idea that pain, yes, it resides in the brain. Pain is an experience that is going to be impacted by things inside your body and things in the outside world. And pain is something that we don't yet know everything about, but we don't have to be able to treat it and help you feel better, is going to serve our patients a ton better, serve us a ton better. We lose that helplessness and we don't know what to do. They lose that helplessness. And then all of a sudden we're reinforcing an adaptive process rather than reinforcing an escalation.
As I'm glancing through my schedule for the day, give me some example of some sorts of things that you're talking about where we should be thinking in these terms.
Goodness. I would say the kid that's coming in with pain that is interfering with being able to go to school, pain that is interfering with being able to sleep or do their normal activities. Certainly anybody who's coming in with chronic abdominal pain or belly pain that seems to be interfering with being able to get out of bed and go to school. Headaches, fall into this general category. Headache disorders and chronic migraines fall into this category. Chronic fatigue, right? Our kids who are just really tired. A lot of our long COVID kids are experiencing pain as one of their primary symptoms. Certainly kids with any kind of autonomic dysfunction like POTS or things like that. But I think a PCP's office, what I think happens is you guys are on the front lines of like the kid who comes in and says, I don't feel so good. Something feels off. I feel dizzy. I feel nauseated. I hurt. Any kind of body discomfort that doesn't have a quick and easy target, we can start to think about in the same way, because working on function isn't going to have side effects. It's going to help them function.
One of the beauties of what happens in my life in my office is that I can have an ongoing relationship with this patient. And so what I think what you're suggesting is I don't have to exhaust all the other possibilities before I start thinking about addressing pain and function, that I don't have to have run every lab and done every bit of radiography that can be done, while I still going to be thinking in the back of my mind, is there something that I'm missing? If I'm not addressing pain and function from the first, I'm missing opportunities, it sounds like.
I would agree with that completely. I think one of the things that I am continually kind of pushing against and fighting against is this idea that a functional pain disorder is a diagnosis of exclusion. And I don't understand why it can't early on be in that differential, why we can't be working on functioning. Because if I have a patient who has pain because they have arthritis, I'm going to treat them the same way as a kid who has pain because they have cancer, as a kid who has pain because they have migraines. How I treat the pain to keep kids functioning is empowering them to use their nervous system to work for them instead of against them. And so this idea that we do that only with pains that don't fall into, some of these other more, I don't want to say legitimate categories, but other traditionally positive categories.
But Dedee, I think that's such an important point, because I was just thinking the same thing, that if we delegitimize the experience of pain, it's sort of like we say, well, if I can't think of anything else, then let's think about getting you back on your feet. But that really means there are way too many hoops to jump through. And it's sort of like somebody who sprains their ankle and then never walks again because it hurt. That really we're supposed to be coaching them through getting better.
Exactly. And I think for some kids, those pain receptors are much more sensitive than other kids, but we're not necessarily going to know which kids are which. And so if we are waiting to kind of like have it all fall out, and now the kid who's 6 months out is still in pain, suddenly now needs something more, treating everybody the same on the front end, talking to them about function, talking to them about how your mental health and your attention and things like that can affect your experience of pain. It doesn't hurt us on the front end, but it might actually prevent us from having some of those kids fall into that long-standing chronic pain category.
And if someone is in the category, someone who is more likely to perceive pain, it's not like we have to ask them to wear a punitive armband, that they also deserve.
Right. And again, like I hate using the words like legitimate. I hate using words like you deserve to not have pain and you don't deserve to have pain and things like that. But I think we as humans have some implicit bias about pain, whether it was trained into us, whether we, have somehow picked it up along the way. The language of pain really kind of lends itself to some of that categorization. And I think getting out of that is a very difficult thing to do. Like I'm making it sound easy, but it's years of practice of really trying to kind of just be in the moment with a patient.
And it's individualized for every person.
Mm-hmm.
So over the next couple of weeks, we're going to be looking at 5 domains for both looking at what's going on and treating kids. I want to just introduce those domains today and define those domains, and then we'll talk more in detail next week. So I was trying to come up with a clever mnemonic for this. I put these in a mnemonic generator, and all of them were just terrible. So we'll just
sure.
I didn't realize there was such thing as mnemonic generators, but AI has given us everything. So the first one is a physical domain. What is the physical domain?
So I think the physical domain is what you would typically see a patient coming into you with or for, right? What are my physical symptoms? And what am I experiencing in this kind of illness space? Sometimes it might be things like migraine, right? Or daily head pain. It could be fatigue. It could be joint pain, body pain. I feel like a lot of kids that I see with chronic abdominal symptoms, sometimes it's chronic nausea, sometimes it's pain in the belly, sometimes it's pain with eating or swallowing, sometimes it's pain with motility, sometimes it's pain related to the sight of food, right?
Mhm.
All
Sure.
of those things kind of fall into that physical category. And I think that in general, when we're looking at that, that's probably the category that most people are most comfortable exploring.
Right, right. You hurt because your arm is broken.
Mm-hmm,
Okay.
mm-hmm.
All right. Second domain is functional. How's that different from physical?
So functional, I always say to kids when I'm trying to describe function, it's if I look at you and I say, what do I expect you at your age to be able to do? So you're an 11-year-old kid. I expect 11-year-olds to be able to do X, Y, and Z. How well are you doing in those things? So how are you spending your days? How are you spending your active wake cycle and sleep cycle? Are you having times where you're working really hard and doing everything? Are you having times where you're crashing and burning? What does it look like for you on an average day? Do you have good days and bad days? What do those look like? So it's just kind of, what do you do?
Third domain is the social environmental domain.
Yeah,
What's
this
that?
is the hardest one. This is all those things we can't control about the world around us,
Mhm.
right? So things like friends, social anxiety is pretty common among kids that struggle with function. And it's hard to tell if it's a precursor, or if it's something that kind of hangs on after the experience of having pain and having been out of function for a while. But certainly that social domain and how you're interacting with peers, with school, with your family, and the world around you is really what we're looking at in that domain.
Excellent. Fourth domain is the psychological domain.
So that is, are there any psychological factors that could be interfering with you getting better? I think one of the things that I like to talk about when I talk about the psychological domain is that when people have unexplained pain, or pain that we think is out of proportion with what we would anticipate, oftentimes our go-to is they must be anxious.
Right, right,
And
right.
I'm laughing because I really have never had a patient come to me for chronic pain and not say, you don't think this is anxiety, do you? Because I don't think I have anxiety. It really does happen a lot and it comes up a lot. And yes, there is a significant percentage, like 40 to 60% of kids, there's a co-occurrence of some anxiety and a pain disorder. But there's a significant percentage that there isn't any co-occurrence. And so really looking at those things that could get in the way, but not making the assumption that psychological factors are the primary mover of the process.
Excellent. And then the final domain is the cognitive behavioral domain. And how's that different from the psychological domain?
So cognitive behavioral domain is like my favorite space because that's where all the change is taking place when we're looking at changes in function. Cognitive, fancy word for what you think. Behavior is what you do. And it turns out that people in pain create certain biased and reinforcing pathways for how they think about their illness and how they think about their pain that can actually exacerbate symptoms, create catastrophic thinking, things like that. And the illness behaviors, things that people are doing that are either reinforcing the pain cycle or helping them feel better.
Do you think they've ever thought about formulating a kind of therapy that integrates cognition and behavior?
I don't know, but it works really well for pain if they do it.
I tell you, you invent that, you're going to be a famous person.
Right?
Well, I am very intrigued. So I think we've sort of got a foundation to stand on now. Now, over the next 2 weeks, I think you'll be able to teach us how to make a difference. Because you're right that statistics we were talking about at the first are just right on. And I think having something in hand and recognizing that what we're doing here is so important to the patients.
Mhm.
It's as important as treating strep and the other things that we do, and in many ways has a much longer lasting benefit.
It does. The skills that kids learn when they learn how to manage hard things really help them move forward, not just in the realm of how do I manage my body and my pain, but how do I engage with the world around me? How do I grow as a human? And how much confidence do I have in my own ability to read my body appropriately?
Right, right. Because you're the only person reading it from the inside.
Mhm.
And anything we can do to help with that is so vital. Well, I look forward to talking to you about this in the next couple of weeks. Thank you for spending some time with us today. We hope you'll come back next week. For those of you who have questions, please send your questions to questions@vcurb.com, and we'll address those in a couple of weeks. Dr. Caplin, thank you for your time.
Oh my gosh, thank you so much.
All right, talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.